Hello, my name is James Ekman. I am Professor Emeritus of Hematology and Oncology at Emory University School of Medicine and founding director of the Georgia Comprehensive Sickle Cell Center in Grady Health System. I will be presenting Managing Chronic Transfusion and Sickle Cell Disease, Module 3 of the series on reducing complications of therapeutic blood transfusion in sickle cell disease. Specifically, I will review the role of chronic transfusion in managing and preventing CNS system and other complications in sickle cell disease, discuss prevention and management of alloimmunization in these individuals on chronic transfusion, explain the importance of iron overload in chronically transfused patients with sickle cell disease, and introduce the importance of management of iron overload in these patients on chronic transfusion. We'll start off with a case. The case is that of a 4-year-old boy with sickle cell disease who was brought to the emergency room with a history of not talking, falling to the right with trying to stand, and not using his right hand or arm. Physical findings include a right central seventh nerve palsy and severe weakness of the right arm and leg. His laboratory results are unchanged from his usual baseline, with a hemoglobin of 8.6 grams per deciliter, elevated white count and platelet count, and a reticulocyte percentage of 13%. Indirect bilirubin, LDH, and AST are all elevated. The child underwent emergency radiologic evaluation, including magnetic resonance imaging and arteriogram, shown here. The brain CT showed a large area of hypodensity on the left. The panel on the left shows the patient's MRI. It reveals a large area of enhancement on the left side of the brain consistent with infarction. The MR arteriogram seen on the right panel shows total obstruction of the left middle cerebral artery at its origin. A diagnosis of acute thrombotic stroke was made and therapy was planned. Would you treat the patient with A, fluids and aspirin, B, simple transfusion to a hemoglobin of 12 grams per deciliter, C, simple transfusion to a hemoglobin of 10 grams per deciliter, D, red cell exchange to achieve a hemoglobin of 10 grams per deciliter with less than 30% hemoglobin S? The correct answer is D, red cell exchange to achieve a hemoglobin of 10 grams per deciliter with less than 30% hemoglobin S is the indicated therapy. Fluids might be indicated if the patient was dehydrated, but should be administered carefully. And aspirin would be considered in an adult, but is not commonly given to children. Simple transfusion to a hemoglobin of 12 grams per deciliter is contraindicated because it would increase blood viscosity, potentially decreasing blood flow to the area of ischemic damage. Simple transfusion to a hemoglobin of 10 grams per deciliter is considered inadequate. In 2014, the NIH published an expert panel report on evidence-based management of sickle cell disease. This report addresses the management of acute stroke by stating that consultation should be obtained by a neurological physician with expertise in sickle cell disease, and prompt neuroimaging should be performed. Immediate treatment is red cell exchange using erythrocytophoresis or manual techniques based on availability. The goal is to achieve a hemoglobin level of about 10 grams per deciliter and a hemoglobin S percentage of less than 30%. The patient should be maintained on monthly simple or exchange transfusion, maintaining the target goal to reduce the very high risk of recurrence. Units transfused should be screen negative for hemoglobin S so that the hemoglobin S percentage can be used to accurately monitor therapy. Present information suggests this therapy should be continued for the life of the patient. If it is not possible to maintain the transfusions, treatment with hydroxyurea may be considered as an alternative. However, the switch trial showed the risk of recurrent stroke was high in children transitioned to hydroxyurea. There are not randomized trials in adults and very little literature to guide management of adult sickle cell patients with a history of stroke. The NIH expert panel recommends chronic monthly transfusion for children and adults who have had an overt stroke. This is based on a large number of studies that show high risk of recurrence of up to 75% and a reduction to 10 to 15% with chronic transfusion. Based on the results of the STOP trial, annual screening of children for increased risk using transcranial Doppler is recommended, and all children with repeated values above 200 centimeters per second should be transfused monthly. Patients with severe sickle cell disease may require chronic transfusions. Those who have recurrent pain episodes that are not improved with hydroxyurea therapy are often given trials of chronic transfusion to improve quality of life. Chronic transfusion may be considered for patients who have frequent pain episodes that are accompanied by drops in hemoglobin to symptomatic levels. Patients with recurrent episodes of acute chest that do not decrease with hydroxyurea therapy should also be considered for chronic transfusion. Other complications of sickle cell disease that may be indications for chronic transfusion are renal insufficiency that results in decreased erythropoietin level and direct suppression of erythropoiesis, producing symptomatic anemia. Also, older patients with chronic heart failure or hypoxia from lung disease require higher hemoglobin levels to minimize their symptoms, levels that can only be maintained with regular transfusion. Consultation with a hematologist with expertise in management of patients with sickle cell disease should take place before starting a chronic transfusion program. Individuals with sickle cell disease who are transfused are at risk for alloimmunization. More information about this complication can be found in the introduction module and the first case module in this series. Keeping the risk of alloimmunization in mind, how would you match this patient's blood for transfusion? A. Cross-match for ABO, RHD compatibility only. B. Cross-match for ABO, RHD, and RHCE and KEL compatibility. C. Cross-match for ABO, RHD compatibility plus extended matching beyond RHCE and KEL. D. Defer to the blood bank director. The correct answer is B. Cross-match for ABO, RHD, and RHCE and KEL compatibility is currently recommended in the NIH expert report and the British Committee Standards for Hematology Guidelines. Cross-match for ABO-RHD compatibility only is not considered adequate because of the high rate of alloimmunization in chronically transfused sickle cell patients. Cross-match for ABO-RHD compatibility plus extended matching beyond RHCE and KEL is practiced by some programs, but it is expensive and requires special donor programs to provide sufficient blood. Consultation with the blood bank director is desirable. However, the clinicians directly caring for the patient need to assess the most appropriate approach based on the clinical situation. The NIH recommendations suggest that the blood cell units that are transfused to sickle cell patients should be matched for ABO, RHD, CE, and KEL antigens. Because of the concern for increasing viscosity in patients with sickle cell disease, the target hemoglobin should be no greater than 10 grams per deciliter. The hemoglobin S percentage should be maintained at less than 30%. It is also recommended to include input from sickle cell specialists and to use established monitoring protocol for chronic transfusion. Despite appropriate clinical management, our patient develops 2 alloantibodies after 6 months of transfusion. How would you modify your matching of the patient for future transfusions? A. Cross-match for ABO-RHD compatibility only. B. Cross-match for ABO-RHD compatibility and the antigens to which the patient has antibodies. C. Cross-match for ABO-RHD and RHCE and KEL compatibility and the antigens to which the patient has antibodies. D. Cross-match for ABO-RHD compatibility, extended matching beyond RHCE, KEL, and the antigens to which the patient has alloantibodies. And E. Defer to the blood bank director. This is a difficult clinical situation. For most centers, C is the correct answer. Cross-match for ABO-RHD, RHCE and KEL compatibility, and the antigens to which the patient has antibodies. For other centers, the answer is D, because the patient has potential to make antibodies to all of these antigens. This approach is expensive because it requires screening of many donor units in order to obtain compatible blood. Donor recruitment targeted to African Americans is necessary to obtain sufficient compatible units. Answers A and B are considered inadequate approaches to this clinical problem because patients who form alloantibodies will often go on to form antibodies to all of the significant minor antigens they lack on their red cells and may form autoantibodies. Regarding answer E, the clinician should not defer a decision to the blood bank director completely, but the director would need to provide input on the feasibility of the approach to matching based on the complexity of the patient's phenotype. It is important to remember that none of these options completely prevent further alloantibodies because individuals may receive a portion of their transfusion in health systems that do not follow these practices. The variation in transfusion practices across health systems is largely due to the absence of randomized trials and limited prospective data on matching these patients. This slide provides the practices of a number of academic centers that care for large sickle populations. All centers match for ABO, DE, C, KEL, and the antigen for which the patient has alloantibodies at a minimum. Many do extended matching for some or all of these antigens for all of the antigens the patient lacks, and some are adding molecular-based testing to determine the phenotype of the patient and the donor units. There is clearly no universal approach to this problem, and prospective randomized trials are needed to determine the best approaches based on clinical outcomes, cost, and feasibility. Our patient continues to be transfused monthly with extensively matched donor units for all of the red cell antigen the patient lacks. Nevertheless, the patient goes on to develop a warm antibody. What is now indicated? A. Continue transfusion with units matched to the patient's red cell phenotype. Do molecular testing for Rh polymorphisms. C. Stop transfusions and start hydroxyurea, increasing to maximally tolerated dose. D. Stop transfusions and closely monitor the patient. E. Defer to the blood bank director. Again, answering this scenario is difficult because there are many possible approaches to this problem and no evidence base that provides solid recommendations. The best choices are B and C. Immunosuppression may also be indicated. Molecular testing for Rh polymorphism should be done on all transfused patients who appear to develop autoantibodies because many of these are in fact alloantibodies to polymorphisms in the minor blood group antigens. Also, in this patient, one could consider stopping transfusions and starting hydroxyurea and increasing the dose to a maximally tolerated dose. Hydroxyurea therapy appears to reduce risk of recurrent stroke, although not as effectively as chronic transfusion. Continued transfusion with units matched to the patient's red cell phenotype is not recommended because the transfused cells will be hemolyzed and further destruction of the patient's own cells is likely. Stopping transfusions and closely monitoring the patient is only considered if transfusions and hydroxyurea cannot be safely administered. Certainly consultation, but not deferral to the blood bank director is indicated, and sickle cell experts from around the world should be contacted for input in these very difficult clinical dilemmas. The other major and universal complication of chronic transfusion in sickle cell disease that must be considered is iron overload. Red cells are a rich source of iron, and there are no natural mechanisms for the elimination of significant amounts of iron from the body. The concentration of iron in red cells is about 1 milligram per mil of packed cells, so each unit of blood contains about 200 milligrams of iron. Iron overload develops quickly in chronically transfused patients. The toxicity profile of iron in sickle cell disease appears to be different than that in thalassemia or hemochromatosis because of the chronic inflammatory state that is present with sickle cell disease. There is extensive loading of the iron in the reticuloendothelial system before organ damage occurs, and the liver appears to be the major target organ. But the heart and endocrine glands can also be affected with severe iron overload. How do you monitor a patient for iron overload? Here are some of the methods that can be used for monitoring iron overload in patients with sickle cell disease receiving chronic transfusion. They include monitoring the number of units transfused, serum ferritin, measuring liver iron concentration, cardiac T2 star for determination of hard iron quantification, and other. There are differences in the reliability, feasibility, and costs of each. One of the least expensive and most cost-effective methods for assessing iron burden is to count the number of units the patient receives over his or her lifetime. This requires careful record keeping both by patients and healthcare providers because, as is shown here, sickle cell patients are seen and transfused at multiple hospitals. This study reports a group of patients followed at medical centers in Seattle and Pittsburgh using a registry of alloimmunized patients. As you can see in the figure on the left, alloimmunized patients were transfused at up to 8 different hospitals in addition to the reference hospital. Shown on the right, many of them had over 20 admissions to these hospitals where they may have been transfused. As a result, the patients, their families, and caregivers are the only accurate source of information about the total number of units an individual receives. They will need to be educated and encouraged to keep an accurate journal of all transfusions and to report this data to the healthcare providers who monitor their iron status so it can be made part of their permanent transfusion record. Serum ferritin is an inexpensive test that is used to monitor iron levels. In this study of 37 patients with sickle cell anemia, the blue circles, and 74 patients with thalassemia, the white circles, hepatic iron load was measured by non-invasive magnetic methods, and serum ferritin was measured by immunoassay. There was a strong correlation between the plasma ferritin and hepatic iron load for higher plasma ferritin levels. For low ferritin levels, the correlation between plasma ferritin and liver iron load was not as strong. It is important to note that the serum ferritin levels can be affected by inflammation, abnormal liver function, and metabolic deficiencies such as vitamin C deficiency. In addition, serum ferritin becomes much less reliable measure of iron level once chelation therapy is started. Another problem with ferritin is that there is no clinical data that relates risk from iron overload to ferritin level in sickle cell disease. The only available data is in thalassemia patients who were treated at University College London Hospital and followed up to 15 years. Patients who had a ferritin level of less than 2,500 micrograms per liter on more than 2/3 of all occasions had better survival probability compared to those who had ferritin levels of greater than 2,500 micrograms per liter on more than 1/3 of all occasions. These data suggest that maintenance of ferritin levels at less than 2,500 micrograms per liter is a positive prognostic indicator for increased survival in thalassemia. However, there are no comparable data in sickle cell disease. This is still considered a valid clinical endpoint. Direct measurement of organ iron is the best method for assessing iron overload. Liver biopsy with analysis of tissue iron is the gold standard for assessing total body iron burden. The study shown here assessed the validity of using hepatic iron measurements to evaluate total body iron from 54 patients who had undergone bone marrow transplant for beta thalassemia and who were receiving phlebotomy to remove excess iron. There was excellent correlation between the total body iron removed and the iron concentration determined by liver biopsy. The left panel, depicting 23 samples that were less than 1 gram dry liver weight, show greater variation than the right panel, which depicts 25 samples that were greater than 1 milligram dry liver weight. In the larger samples, there is a closer and excellent correlation between hepatic iron concentration and the total body iron. There is a very strong correlation between hepatic iron concentration and body iron stores. If the liver biopsy sample is large enough, care is taken to avoid contamination of the sample, and the analysis is done in a laboratory with expertise in tissue iron measurement. New methods using MRI with special techniques have been developed that are excellent for assessing iron concentration in organs. They are less invasive, they are much less susceptible to sampling errors, and they can also biopsy organs where they can also assess iron in organs where biopsy has unacceptable risks. They also provide concurrent assessment of organ damage. The goal of iron chelation therapy is to control body iron while minimizing the toxicity associated with chelators. While it is known that hepatic iron content correlates with risk of complications and early death, limited availability of clinical data for patients with sickle cell disease means that iron overload risk management guidelines have mainly been derived from clinical experience with patients with hereditary hemochromatosis and beta thalassemia major. Hepatic iron levels for normal individuals are approximately 0.6 to 1.2 milligrams iron per gram liver dry weight. The risk for iron-induced toxicity, including hepatic fibrosis and diabetes mellitus, increases with hepatic iron levels of greater than 7 milligrams iron per gram liver weight, per gram dry liver weight. There is an increased risk of iron-induced cardiac disease and early death with hepatic iron levels of greater than 15 milligrams iron per gram liver dry weight. If patients with thalassemia major are not treated with chelators, their hepatic iron will continue to increase from transfusions, reaching approximately 30 milligrams of iron per gram liver dry weight by age 10. These patients have a profoundly increased risk for morbidity and early death. Although the clinical care of iron overload in patients with sickle cell disease generally follows the recommendations for thalassemia major, the organ distribution and location of iron in the tissues is different in hereditary hemochromatosis, thalassemia, and sickle cell disease. In patients with hereditary hemochromatosis, iron deposits almost exclusively in the hepatocyte, while iron deposits initially in the lipid reticulum endothelial cells in sickle cell patients. In thalassemia, iron is deposited in both locations, causing risks more similar to hereditary hemochromatosis. Therefore, data needs to be obtained to determine the risk in sickle cell disease, which is likely between that of hereditary hemochromatosis and beta thalassemia. Until such data is available, effort should be directed at least keeping the liver iron concentration at less than 7 milligrams per gram liver dry weight. These recommendations are summarized in the NIH expert panel report. In patients who receive long-term transfusion, perform serial assessment of iron overload to include validated liver iron quantification methods such as liver biopsy, magnetic resonance imaging R2, T2 star, and R2 star. The optimal frequency of assessment has not been established and will be based in part on individual patients' characteristics. Administer iron chelation therapy with consultation with a hematologist to persons with sickle cell disease and documented transfusional acquired iron overload. Phlebotomy and chelation drugs can be used for iron removal. Simple phlebotomy can be used in patients with robust increases in hemoglobin in response to hydroxyurea therapy and in patients cured with bone marrow transplant. Erythrocytophoresis removes considerable iron and can be used to slow iron accumulation and can be used in combination with chelation to facilitate iron removal in chronic iron overloaded individuals. There are presently 3 approved drugs available for chelation therapy. Deferoxamine is the oldest and has the most clinical experience. It requires parenteral administration by infusion over prolonged periods daily by subcutaneous or intravenous routes. There is renal and biliary excretion. Side effects include local irritation, growth retardation, skeletal changes, oculatory and auditory toxicity, and renal toxicity. Infection is also increased. Deferoprone was the first oral iron chelator. Pills are usually given 3 times a day. It may be more effective in removing cardiac iron. Side effects include nausea, vomiting, diarrhea, abdominal pain, neutropenia, and agranulocytosis. Hepatic toxicity and arthralgia also occurs. Deferocerox is given once a day with a suspension or pill form. It has more favorable side effects than other chelators. The pill may have fewer side effects than the suspension. Side effects include gastrointestinal symptoms, skin rash, renal and hepatic toxicity, eye damage, and hearing toxicity. These drugs may also be combined with erythrocytophoresis in patients with severe iron overload. They are also given in combination to treat severe iron overload to maximize iron removal while minimizing toxicity. Chelation therapy should include consultation with clinicians with expertise in the management of iron overload. The effectiveness of chelation should be monitored regularly and the dose and chelator adjustments made based on tissue iron determinations. Intensive education and motivation must be provided for patients and families at initiation and during chelation therapy. Inadequate adherence to therapy is a major challenge in achieving negative iron balance in chronically transfused patients. Successful treatment requires a team of health professionals with experience in managing these patients. In summary, it is important to discuss the need for management of iron overload with all patients and families before chronic transfusion therapy is undertaken. There should be a care plan that is developed in coordination with subspecialists who are knowledgeable in the management of iron overload. Clinicians must keep accurate treatment records, as should patients and their families who need to record every transfusion received. Erythrocytophoresis may be considered as a means of preventing and managing iron overload. Once iron overload is documented, chelation therapy is required and may be lifelong in individuals receiving simple transfusions. Strict adherence to chelation is critical for a positive outcome, and patients must be carefully monitored for specific chelator-associated toxicity. Chronic transfusion is indicated for stroke treatment and prevention of other serious complications in select patients. Alloimmunization is a common problem in chronically transfused sickle cell patients, and it requires prevention by extended phenotypic matching. Management of transfusion in patients with alloantibodies is a challenge that requires collaboration between the patient, clinical care team, and blood bank. Iron overload is a universal complication of transfusion that requires monitoring and treatment in all chronically transfused sickle cell patients. Iron overload is an universal complication of transfusion that requires monitoring and treatment in all chronically transfused sickle cell patients. Thank you.